The next class of drugs that we'll talk about are proton pump inhibitors. And this is a class of potentially inappropriate medications that maybe haven't received as much attention as these drug classes that we previously discussed. The use of our little purple pills has been wide-reaching, but the long-term consequences of their use are now becoming more known, and greater attention needs to be given to their long-term use, especially in older adults. The contribution of long-term proton pump inhibitor use to polypharmacy is evident in this first bullet on this slide, where up to 70% of prescriptions for proton pump inhibitors have no actual apparent indication. And one of the things that contributes to that is that up to 50% of hospitalized patients are discharged on a proton pump inhibitor when they weren't on a proton pump inhibitor when they were admitted to the hospital. Proton pump inhibitors have value when someone is in the hospital and they're in a reclined position, and that there's some justification for that. However, when they're discharged back to their home setting, that need may not no longer be there, yet the medication continues. Long-term proton pump inhibitor use is only indicated for a handful of situations, really, including esophagitis, hypersecretion, and refractory reflux. So again, they're more designed for shorter durations and not for chronic use. And this long-term use, often for potentially acute needs, has led to some dramatic consequences, primarily resulting from the reduction in stomach acidity. There's a reason why our bodies have the pH that we do. And some of the adverse effects of not having that are an increase in C. diff infections, community-acquired pneumonia. We need acid in our bodies to absorb calcium. And so with that, we can see hip fractures as well as B12 deficiency. And PPIs also can impact our kidneys and have some connection to dementia as well. A challenge with discontinuing proton pump inhibitors is that there can be a rebound reflux in up to 10% of individuals when discontinuing the med. This, however, can be made more tolerable by gradually decreasing the dose, using the PPI when needed while doing the dose reductions, and taking non-pharmacologic approaches to reduce reflux, as well as the occasional use of an antacid as well, as long as that doesn't cause any interactions with other medications or conditions. We also have other potentially inappropriate medications to use with caution in older adults. Anticoagulants and antiplatelets need more caution as we age due to our increased risk of falls and bleeding. We have potential issues with antidepressants and mood stabilizers, and Bactrim, sulfamethoxazole, trimethoprim has the potential for hyperkalemia with ACE inhibitors and ARBs. So again, lots of consideration that needs to be done in older adults. And again, I can't stress enough the need for that risk versus benefit discussion with patients and their families. So how do we address polypharmacy? What resources are available to help us with this? Well, the first step to addressing polypharmacy is having a comprehensive medication review and looking for drugs which are either causing or, at a minimum, contributing to potential symptoms. This is where, again, that 4M framework is important. So there's a variety of symptoms that we can look to see whether or not they are drug related. So if someone that is on a benzodiazepine, for example, is talking about fatigue and tiredness or having falls, we need to be looking at that drug as a potential cause. Constipation and certain incontinence. We can look at our anticholinergics. There's also loss of appetite, so weight loss, potentially weight gain can be an issue as well. All of these rather standard types of symptoms that we may attribute to something else, we do need to take a look at medications as well to review for possible issues there. The first option to preventing and avoiding polypharmacy altogether is by taking a proactive approach. This can be accomplished by all items on this slide, and these are also useful to address active cases of polypharmacy. But some of these examples include having a medication list with diagnosis. That is very important, and that medication list should include over-the-counter medications and supplements as well, and that should be brought to a visit with every provider so that everyone is assured that updated medication lists are on file. There's the opportunity for what we call brown bag visits, where everyone just, you toss all your meds in a brown bag and you bring it in for us to look at. And this is a great opportunity. I've done these before in assisted living facilities, and it's amazing some of the things that are brought in, because you ask them to bring in everything they got in their medicine cabinet. And those provide some really good opportunities to address polypharmacy situations. Of course, I'm going to advocate for utilizing your pharmacist for comprehensive medication management, medication therapy management. One example of this that we have in North Dakota is utilizing OneRx, which is a screening for people receiving opioids for risk of opioid misuse and overdose. We have lots of good tools available to us, including the Beers list, which we'll talk about here a little bit more shortly. Medication reconciliation is a key when you have transitions of care occurring. It's important that we have communication with all providers for the individual, including specialists and primary care, and their pharmacy where they're receiving the medications from. A great example of how medication reconciliation can be improved is med-to-bed programs, where the medications are given to an individual before they are discharged from the hospital, so that they have their home meds on hand with them, they understand the changes that have been made, and then having that information communicated to their other providers. Also, the proper use of electronic health records can also aid with medication reconciliation. And finally, having that shared decision-making and patient engagement to understand what matters to that patient can help with alignment and avoiding polypharmacy. In addition to on this slide, I would also mention the importance of considering non-pharmacologic alternatives as well as primary options where available. Again, trying to avoid there's a med for that type of perspective. For active instances of polypharmacy, we need to look at deprescribing or the gradual dose reduction and elimination of unnecessary medications. Healthcare professionals have a reluctance to deprescribe, or at least some do, as they think patients and families may object to discontinuing chronic meds. However, a study by Reeve and others in the Journal of the American Medical Association found that 90% of patients are willing to stop a medication if it's recommended to them by their physician. So it can be done. They are open to these options, especially when presented to them in the right way. Another challenge with deprescribing is that there are not as many evidence-based practices on how to do such. There is always evidence on how to initiate treatment, but not as much around discontinuing it. Thankfully, we have more tools becoming available to assist us with this. And these tools include a variety of options for both the provider to familiarize themselves with opportunities to deprescribe and taper, as well as to the patient. So some of these tools include algorithms, pamphlets, checklists and decision aids, as well as our increasing body of research that is available around how to deprescribe and how to taper meds. And a great example of this, a great resource for this, is the website deprescribing.org. This growing website originates in Canada and has materials for both prescribers and patients to help make decisions regarding deprescribing. This includes a lot of those tools that we mentioned on the previous slides, such as algorithms, and they have algorithms to help with deprescribing proton pump inhibitors, antihyperglycemics, antipsychotics, benzodiazepines, and others. So a lot of those red flag drug classes that we talked about. Pamphlets with patient facing education are also available to help them understand the opportunities that are available, and again, some of that risk versus benefit. Another helpful tool is the website choosingwisely.org. This website, again, has clinical and patient-focused materials to facilitate conversations regarding the necessity of medications, testing, and other medical treatments. While designed to be used in conversations that happen before initiating therapy, they can also be helpful when discussing deprescribing. The Beers criteria is a standard in the United States for identifying potentially inappropriate medications. So this is another resource available to us. And no, the Beers list doesn't have anything to do with alcoholic beverages. The Beers list was started in 1991 by a geriatrician named Mark Beers. It offers evidence-based recommendations on drugs to avoid in the elderly, along with the rationale for their use or for not using them, and a grading on the quality of the evidence behind the recommendation and the strength of the recommendation. The Beers criteria should be viewed through the lens of a clinical judgment to offer safer non-pharmacologic and pharmacologic treatments. The Beers list is currently maintained and published by the American Geriatric Society, utilizing a panel of experts, and was last updated in 2019. It's the foundation for potentially inappropriate medication lists used in a wide variety of quality measures from national organizations, including CMS and NCQA and the Joint Commission.